Shall we start? Are we ready? All right. I'm Shirley Fenton. I'm the Managing Director of the Waterloo Institute for Health Informatics Research. I welcome you here today. I'm so pleased to see a nice audience for our guest from the Netherlands, from the University of Twente. Before we start, I have a couple of announcements, if I can keep them here. We also run another seminar series called the Smarter Health Seminar Series. You can attend in person because it's right here on campus, but you can also come in via webcast or by video conference if you're part of the Ontario Telemedicine Network. And our guest speaker, which will be on Tuesday, September the 29th, in the room right next door, 1302, is Brands Myers, who is the Director of Healthcare Business Development, Cisco Canada. And he'll be talking about intelligent hospitals, how technology can transform healthcare beyond the EHR. So I think it should be a very interesting talk, and I hope you can join us on that day. That's from 3 to 4:30 p.m. Our next speaker in this seminar series, which is our research seminar series, will be given by Catherine Burns, who is a professor in systems design engineering at the University of Waterloo. And she'll be talking about understanding cognitive work in healthcare. So that will be held on Wednesday, October the 7th from 12 to 1 in the room next door, in room Davis Center 1302. So I hope you will all come back and join us that day. So I'm very pleased that we have our visitors here from the University of Twente, who will be talking about e-disease management research projects at the Center for eHealth Research and Disease Management at their university. So I don't want to take too much time about talking about them because I really want them to talk. So let me introduce to you Dr. Hans Ozenbard, who will introduce our speakers and begin the discussion and their presentation. We ask that you hold your questions to the end so that we can get a mic to you so we can get the questions and the answers recorded on this video recording as well. So we are recording this presentation as well as webcasting. So without any further ado, Hans, will you come forward?
Well, I don't think I need the microphone, or do you need it for?
Yes, we do for the
All right. Thank you very much for your welcome, Shirley. My name is Hans Osterbaert. I'm affiliated to the National Institute of Public Health and to the University of Twente. In both affiliations, I work in the field of eHealth or consumer health informatics. At the National Institute of Public Health, I'm a product manager in the field of e-public health information. Like in Canada, a client-centered healthcare system is the present ideology, and people need the information to make these choices, and we provide this information via this portal. The second job I have at this National Institute of Public Health is a research job in eHealth. For instance, we study the effectiveness of online decision aids within a kind of shared decision-making model between patients and doctors. But of course, I'm here in my job for the University of Twente. We are developing a cooperation with the University of Waterloo, university-wide, but we start in this mutual field of e-disease management and health informatics, and we're very happy to be here to prepare this cooperation. You can think of student exchange or staff exchange and mutual research proposals. And on the cookie table there's a little book. It's very new of the University of Twente. You can read a little about this university in the Netherlands. At the University of Twente last year we have erected the Center for eHealth and Research and Disease Management, and head of this institute is Dr. Lisette van Gemert, and she will introduce you to the main themes of research and study at this center, and it's followed by a presentation of Nijhof, who will go deeper into one specific subject. Okay, Lisette? Yeah, I know your voice is a bit
Yes, I have
hampering
a
at the
cough.
moment.
No
Yeah.
flu, but a cough.
If you get in trouble,
Yes, then you will take it
yeah.
over.
Okay.
I don't need to mark. I have this.
Okay.
This will suit. This is okay. I have a cough, so I have a rather strange voice, maybe, but I hope I can do it very well. Hans told me who I am, and I am also the founder of this Center for Disease Management. It was 2008. We launched it, and after a couple of years now, we are a very explosive center now, and we want to cooperate with national but also international institutes in disease management. And last year, I was at Waterloo Institute, and I visited Shirley Fenton, and I met her in an exchange program years, I thought 2006 or 7. 7 at Amsterdam. There was an exchange program between Canada and the Netherlands, but mostly driven by industrial organizations. And I was there speaking as a representative from university, and so we met each other, and I saw a lot of programs and research programs in common we have at the Waterloo University, at the University of Twente and the University of Waterloo. And I will explain something to you for what kind of university we are, what kind of research we are doing. And I have some examples to show you what we are doing and what kind of methods we use and what kind of theories, because you can look at it and ask afterwards questions and show your interest, because I don't know what interest you have. So I have a lot of slides, but I will present them to you to give an idea what we are doing. And Nienke will go in depth to her research about dementia and technology. Is that okay? Yeah. Okay. And this is our new corporate style. It's just a few weeks launched. I hope. And we don't know what this means, but it's like fractals or something. We don't know. Yeah. We are very pleased that we can be here to give a lecture, and we saw at the bottom that e-disease management was scheduled as part of the program. And we also talked this morning about Waterloo Institute and especially health informatics and what they are doing. And those boot camps, that I really like them, and I think that we will do that also in the Netherlands. We have a very similar structured university, so I think that those boot camps must be very nice. In physically sense, also online sense. This is our University of Twente. It's in orange is the Netherlands. It's a small country as part of Europe, and we are located at the eastern part, not in Amsterdam, but on the eastern part, near Germany. It's only 5 kilometers or 3 miles from Germany located. If you look at it, it's a very flat country. It's similar maybe like the Waterloo area is. It is a very small university. We only have 8,000 students compared to Waterloo. It's very small. But in the Netherlands, we only have 3 technical universities, and this is the one. We have 11% students from abroad, and there is a growing exchange from students from abroad, from China, Asian countries, especially. What is different from this university? We are the only university in the Netherlands that combines technical science with health and social sciences. I'm a representative from the behaviorals and health sciences, and we work together with the engineering technology, but it is the only one in the Netherlands that combines the social and the technical research, also in education. We have different corporate slides, you see, all kinds of things on it. We have 6 research institutes, and in red that's our Institute for Behavioral Research, but these institutes, they work together. For instance, we work with the Center for Telematics and Information Technology. They are focusing on technical requirements you need for developing interventions, and we give them the content to make the technical requirements. That's our cooperation. The Faculty of Behavioral Sciences is part, we have a hierarchical structure. It's part of the Institute for Behavioral Research, and the center I founded and which is launched in 2008 is the Center for eHealth and Disease Management. It belongs to the Faculty of Behavioral Sciences and to the Department of Psychology and Communication of Health and Risk. In that department there work sociologists, psychologists, linguists, communication sciences as well. This is a very multidisciplinary research. It is a virtual center. It means we have not a building. We have a platform from researchers and professors and associate professors. And this was a slide for last year, 10 PhD students, but we are growing now at the end of the year to 20 PhD. We have doubled it. But that staff is not doubled, so we have hard to learn. This is the Center for eHealth, which is as part of the IBR, the Behavioral Research Center, and it's in English. We focus on disease management and lifestyle improvement, and I will elaborate on that. What I meant with lifestyle management and disease management. What are our objectives? I pointed 4 objectives here for you, but the main thing for us to do is that we have a lot of knowledge and we want to share the knowledge about social and behavioral research in designing, implementing eHealth or healthcare interventions. We want to share the knowledge with industrial companies and also other universities and also academic centers, so that we have the knowledge and we put our knowledge into practice. And when we are in doing this, putting the knowledge into practice, we have new knowledge and we can redesign healthcare. And that's a cycle of knowledge redesign. And in this sense, it is our university works in some way equal to your Waterloo Health Informatics Institute. We have applied research tradition, not fundamental, but an applied research tradition. That means that students go into the field of health informatics. They work there they do a term like 3 or 4 months, sometimes 9 months, and they work there as a part of their thesis, and they come back, and then after that they are graduated. But there's not a cycle like you have for working 4 months, coming back, and then we don't have that. But initially it looks a little bit the same, that people go abroad, go into practice, and they take the knowledge with them, and then we can rebuild and reshape our models and refine them. And what an important point is, it's point 3, is that we want to translate our knowledge for trade and industry not in real products but in concepts or prototyping. And those prototypes will be developed with the other research institutes for like telematics or technical departments. We have also a societal objective, in the sense that we want to contribute to all the problems that we are facing now of the growing demand of care and the less budget for care. So we also are thinking about how we can reshape healthcare systems in the sense that they are more cost effective and also more efficient. We cooperate at the moment with what is called regional. That is very small in the Netherlands. It's like in your language, it's called province. We work together with all kind of healthcare providers, rehabilitation centers, academic centers, industrial organizations, but also innovation platforms. In the Netherlands, we have healthcare innovation platforms, and we work with them. On a national level also, it's the same. International, we work with some university. We have contact with the University of Toronto with Eisenbach, Günther Eisenbach, do you know him? He is a visiting professor at our university, and we are joining his Medicine 2.0 conference tomorrow. And also we work together with cross-border regions with the University of Münster And Maastricht, that's the university located in the neighborhood of our crossing border. That's from Germany and Belgium. Also, I'm an editor of Journal of Medical Internet Research, a section editor. And we also have international conferences. We want to organize international conference. For instance, the e-telemed conference in St. Maarten, the Dutch Antilles. And also maybe Medicine 2.0 wants to go on tour. Maybe it can be located in our country as well. Each year we organize, we call that a symposium, a conference, about supporting health by technology. And we present at that conference all our research. This is in Dutch, you can read it, but it's about online treatment, online risk or self-testing, home care, care coordination, that means cost-effective methods, online prevention and patient involvement. That are the themes for our conference last year in May. And the conference is visited by researchers and also people from industrial organization and policy. It's also a way to present our PhD work. That's the main thing. Now, what are we focusing on? The main point is that we are focusing on changing lifestyle based on healthcare needs, information needs people have, and their health condition that can be going from staying healthy till living with illness or some disabilities like chronic care people have. Dus our interventions are aimed at changing lifestyle. We use a user-centered design approach. That means that we develop interventions with the aid of all the end users, patients as well as carers, from the beginning, from the start of an intervention. And the aim is to individually tailored solutions, to create tailored information for those patients and carers. Personalized information, we call that also information therapy. I don't know you are familiar with that. It's a California Healthcare Foundation. And we are looking at interventions aimed at independent living as long as possible. And Nienke will talk about that for people with dementia that can stay longer at home. The dimensions of healthcare performance, we look at several outcomes in our research, and that could be safety, access, equity, timely, cost-effective, efficient. These 6 variables or dimensions are based on the Institute of Medicine report. You know that? It is an American report about the critical demands for better healthcare. And we have brought that to our research, and that doesn't mean that each project is focused on safety, access, all the 6 dimensions, but sometimes we look at safety and sometimes more at cost-effective things. But the most exciting part I found personally is that we look at simple, smart, and especially effective technology with emotions in it. How to motivate patients and carers to keep on with a certain treatment program. And that, I think, that's the most challenging part of our research. We have framed several research questions. That means that each PhD project will address one of these 4, sometimes all those 4 questions, but mainly one specific. And we are looking at how we can promote a healthier lifestyle for patients with chronic complaints. For instance, can we have interventions that enhance the quality of life, the safety, or sometimes clinical outcomes, for instance, for people with diabetes. And point 2, that's also an interesting point, is that given the technology, you create new relationships between patients and carers, and how to empower patients and professionals in the decision-making process. And can we create new and proactive collaborations between patients and their carers? And this is I think the crucial part of the disease management programs, if you are familiar with the chronic care models, you see that building a proactive relationship between a patient and a carer is the most important point for changing healthcare and changing lifestyle. Now we look at treatment adherence and efficient healthcare. That means value for money. That's the third point also, how to lower costs. For instance, in the Netherlands, we have the same problems like I think in Canada, for how you can reimburse, how you can make a good healthcare system for anyone, that we can enhance the access to healthcare. We have a different healthcare system than Canada and United States, but also in our country, we are looking at how we can reduce the number of unnecessary office visits. For instance, emergency department visits, half of the percent of that kind of visits are unnecessary, and they cost a lot of money. And we look at just-in-time case programs instead of damage control afterwards. And we think that technology can be a good initiative to promote programs for just-in-time care. Also, we look at how we can use labor, for instance, practitioner nurses or carers in a more effective way. And Nienke will talk about her project. That her project is especially aimed at how we can use carers in a more efficient way. And the last point is more a societal point from how we can identify the best fit of services for our citizens and patients. People have different demands. People with diabetes have different demands than people with dementia, and how we can make a set of services available for them that they can control their own disease. Now, in italics, you see the questions for. Those for our research, how technology can be used in such a way that we can address these four questions, and that's the research that we are on the level we are at the moment. How can technology be accepted by patients but also by carers? But we found out that caregivers are the main part of resistance against innovations based on technology. Now, you're all familiar with the trends in healthcare, same in Canada and in the Netherlands. We have an increasing people with all kinds of chronic diseases, but also diseases that we call comorbidity. They have different, they are blind, they have blindness as well as they have diabetes and as well as dementia. And these people, they're cost a lot of money in the future, and so that's why we focus on chronic care. Chronic care, eHealth and disease management, that means that we need to change the healthcare in pink. That's the focus of the research, people at risk and are chronically ill. And what we are looking for is a balance in our interventions between self-management and professional management. We hope that in people that staying healthier, then you have a lot of self-management skills you can use for control your own health. When you are chronically ill, the more ill you are, the more dependent you are, maybe less efforts we need for self-management. That's why we are looking for a balance between interventions between self-management and professional management. And therefore we think that a proactive approach is needed and that supports patients in some way for self-management. And that's why we think that e-disease management, is IT-enabled disease management, is a good plan for balancing between self-management and professional management. This system of these points are based on the Congressional Budget Office definition. Do you know that in Washington? From the United States, and also the California Healthcare Foundation. Yeah, we looked at what kind of disease management programs they have, and I think the core elements or the key elements for disease management are that you have a coordinated healthcare system for populations, not just for dementia or for diabetes, but for populations with a certain risk and certain conditions, and in which self-care efforts are significant. So we look at what kind of population, what kind of risk user profiles do we have that need or a certain support with technology. And plan of care, evidence-based guidelines, and patient empowerment strategies that are the key elements of a disease management program. And it is a rather holistic way of looking at problems. That means that we are not only interested in economics or clinical outcomes, but a whole schedule. There's clinical, humanistic or humanities, and economic outcomes as well. Now this is the slide of our center. So we look at the professional management and the self-care management, and the things are research as development, implementation, and interventions. And we look at what kind of critical dynamics can influence a good healthcare intervention. What kind of there are several trends in technology. If you look at your university, you have also a history in technology, and maybe you are more focused on information and communication technology. I don't know at the moment that this, but we are looking at information and communication technology, especially at web-based or internet-based communication of guidelines, and especially multidisciplinary guidelines for disease management. And also we are developing decision support platforms as part of disease management programs. We all have interest in the sensing technology, and Nienke will talk about ambient and assisted living combined with video communication, because we believe in systems not only sensing technology, but you have also a video communication part, because the carers and the families should be involved as well. And we look at creative technology. That means you need a format or a design that motivates people to keep on with a treatment program. For instance, feedback and communication and showing emotions via technology is an important part. So internet is one part, but we think that we need other forms, maybe robotica or flowers that can communicate to people. And furthermore, automatically integration of information, for we are building personal health records on a province level, translated in your language. And people have all kinds of information, like a medical record, and that must be available for them in such a way they can handle that kind of information. And it should be combined with the self-management information. That means that we are looking for automatically integration of information. I think that's very difficult to do, but it's very important to do. Now, what kind of methods we have? We are theory-driven in the sense that we use all kinds of behavioral theories, and we use mixed method design, as we always have a qualitative part and a quantitative part in the research. And if we look at developing all kinds of interventions, we have a so-called usability toolkit with all kinds of instruments in it for involving patients and carers in the design process. A focus group and narrative, that means stories of patients, stories of carers, are needed for implementing. But once you have created an intervention, you have to implement it. And we have all kinds of scenario techniques for implementing these kinds of technologies. This is the new one, the business modeling. That means that we are looking for models that have sense for insurance companies, the government, as well as for carers and patients. What is the created value for a decision platform, and what they think what is the benefits for that kind of platform. So we create a common sense about value creation, about what is it worth, what should be the benefits and the drawbacks in advance before you will develop an intervention. I will be very short about this. I talked about chronic care models and disease management models that are rather holistic models, and we use them as an analytic framework for starting our research or for evaluating existing interventions. especially for a behavioral control or for lifestyle changes, we are looking for determinants that influence coping with disease or adherence to a certain program, and for self-control, the social, cultural, and health behavior theories we use. For developing ease of use intervention, we use several usability theories, and for the implementation part, we use innovation models and business modeling techniques. So, and to summarizing all the determinants for health intervention, it is the whole big picture. We look at the technology, individual factors, social cultural factors, and organizational factors. Okay. We have several research projects, and I have scattered them around design projects, evaluation projects, and implementation projects. The design projects refer to disease management projects, portals, creating portals for monitoring, communication, and logistics, and portals for self-management. Evaluation project, that means that we are involved in evaluating several existing projects, and we look at lifestyle projects, online treatments, and also the integration of internet with mobile technology. And the implementation project that Nika will talk about, that is about ambient assisted living and business modeling projects. I have 4 cases. That's maybe too much to talk to you about, but you have all the paper of the whole slide on the video, so you can. I will mention something that I think, some cases that are important for maybe cooperation with Waterloo. We have a cross-border region. That means that we have a lot of problems with infection control. Maybe it's different from Canada, but we have not only the flu, but we have all kinds of multi-resistant bacteria, especially from Germany and Belgium. We have a very strict policy in the Netherlands, but in Belgium and Germany they don't have. But we have a lot of people and patients migrating from in the cross-border section. So we developed a platform, eHealth platform, for avoiding transmission of multi-resistant bacteria. And this project is aimed at to support the decision making of professionals as well as patients, that they have the know-how what to do in case of being infected, and also how they can prevent an infection. And it is based on MRSA, but we will rebuild it now for all kinds of multi-resistant bacteria. It's part of Earth Safety Health Net. It's with Germany, Belgium, and the Netherlands. Now, why I will show this part to you is that it starts with a web-based communication of infection control protocols. And we made a system in such a way that these protocols, that are paper-based protocols, and they are hard to understand, and we combine daily practice information with those protocols in such a way that personnel and patients, public, can understand the information that is relevant for him. For instance, having MRSA, it means that you are not allowed to work in a hospital. And our patients ask, I'm infected with MRSA, am I allowed to visit my grandma? And all that kind of normal daily life questions are incorporated in the system we developed. That means that we have to translate the protocols into a language, a natural language, and that was a hard thing to do, but that we realized that, and that now it's implemented in Germany and in the Netherlands. It will translate it into French and in English as well. Okay, I'll go further on. The model, that's how we have to realize this website. We start with this is the McKinsey model. It's a design model. It starts with a needs assessment, and every block in every block in gray involves a certain part of end users in it, and we have different methods for it, for the needs assessment, as well as the setting up the criteria for the technology, as well as for the implementation. For instance, the MRSA project I thought about, these are 3 it's in German now, three ways of searching for information. You can have a question in your own language. These are the topics created on the information interviews and cards or technique with the end users, and these topics came up that are relevant for them, for a searching, for their searching behavior, and we have frequently asked questions, and the information is presented in video as well as in education and instruction notes, and that is what we are now looking for. Can we make the system in a more elegant way that it's now you have a question, you got an answer, but we want to start a dialogue system that we need the natural language processing as part of that. I will skip this for you. Only thing is, what is an interesting point is that if you are developing a self-management program, then you have a lot of functionalities for self-test, e-consultation, care planning, self-management basis of goal plans. All those functionalities came up with interviewing the end users. And then is the question how we can translate these functionalities into technical requirements. And then we use the technical, we need the technical departments of our university to translate that. And we do this, we built some mock-ups, and every mock-up was prototyped with the end users. And for the presentation of information, the need of information, and this is a starting building up a self-management program is current research. It's not finished yet. And what came up is also from, do we need the internet? Do we need robots? Do we need the Wii? Or what's also an important project is serious gaming. And that's the format for creative technology. This is an evaluation project, but I don't know have the time because Nienke has to present her thing as well. So in the evaluation project, we looked at user-friendliness of a diabetes coach, a lifestyle coach, which has monitoring, communication, and fitness instructions. We look at the system friendliness, the implementation, and the effects. And we know, at the moment, we know that there people like it, but after 2 years, you see a decrease in users. And the main reason for dropouts were no added value. It had no added value anymore, and they were not motivated, and they forgot to use it, and they have no feedback and no triggers. And that's the interesting point from how can we keep them motivated with that kind of programs. This is the part for Nienke, and I think maybe she will talk about that. To summarize, what are the benefits so far? We saw an improved access to care for chronic care patients, and we saw a new collaborationships between patients and their carers by means of online communication, especially online communication that creates new relationships, and that has also a very impact on being prepared for the treatment program, and it enhances the self-control mechanisms. Better self-control we saw for the diabetes case, the lifestyle coach. So we saw that measuring and visualizing clinical values like blood pressure, etc., motivates patients to keep up the good work. And we saw that we can realize saving costs. We can because we have less intramural healthcare now, and less office visits, and more freedom for patients, and more patients can be involved at the same time by means of group education like video consultation. And we saw for the MRSA project with the MRSA web-based system that especially professionals made less errors. They can solve their infection control task quicker and better with less errors. That is, I think, a main point. And the challenges in our view are information management, information therapy, the right information at the right moment, but also in the right format. Integrated care, there's monitoring, communication, no standalone applications. Integration of mobile technology and video communication. Feedback reminders to motivate people. Training is a very important part. And also in the Netherlands, we need a clear policy about legislation, especially with personal health records. And we need new and adequate business models for creating value for technology and to implement technology in the healthcare system. So maybe we can do this after Nienke has finished her presentation with this starts of how we can work together for student exchange or doing proposals together or expert meetings. But that's maybe for the table conversation, I don't know. But I will give the, I hope, yeah, sorry. Okay. For the, have you not?
Do I have to change it myself or?
Okay.
Yes, it is. Okay. Welcome. My name is Nienke Nijhof. I'm a PhD student at the University of Twente. I will present the research I'm doing with the different projects I'm doing. I will tell something about the different projects I'm doing and the research which I'm doing with that projects. That's actually what I just told. Tell something about myself, about my research. I did a quick scan. It's a kind of the simple version of a systematic review. I didn't have the time for that, but I did a quick scan in the literature, what's already researched about dementia and different technology projects, and I will tell you something about that. It's been published in a scientific magazine in the Netherlands. Then I will tell something about my projects I'm doing and about the future projects I will be doing. I can skip this one because Lisette told it already. I'm busy with my PhD research for 2.5 days a week. The other 2.5 days a week I work at a company called Focus Cura, and I'm coordinating the different projects over there we're doing with ICT in the healthcare, and some of these projects are with dementia people, so the projects from my work I use in my research. So for me it's an ideal combination of working in the practical field and doing the research in the theoretical field. Because of the time I will skip actually these digits because you probably already know them. People with dementia, the number is growing as in the world, as in the Netherlands itself, and it costs a lot of money. It's the same here for in the Netherlands. You see like 2008, 180,000 people with dementia, in 2050, 410,000, so it's a big growth. Okay, something more about my PhD research itself. I split it up in 2 head questions because I don't know if you use that over here, extramural settings and intramural settings. Yeah, it's what I mean with extramural. It's like people living at their own home, and the intramural, I mean the people living in the nursing homes. So I do research in 2 different fields. One is in the extramural, so at the home setting. At which moment could you start using technology for people with dementia to postpone the moment of intake in a nursing home, and with that realize financial advantages? In the intramural setting, I'm looking at in what way can technology be helpful with work savings and work shifting for the caregivers working at the nursing homes, take into account the work satisfaction from the professional caregiver. This is the model I hope to have in like a few years when I'm done with my PhD research. This is actually for the home setting. You see if, do you have the red stick? Oh, here. Good yet? Yeah. People are still living at their own home. They're being diagnosed with dementia, and they're going up further in the process of dementia. And I want to, like, this is a timeline, and with the intake moment with technology is like later on, so people can stay at their own home for a longer period of time. That's over here, and people without technology will go to a nursing home earlier. That's what I want to reach, if I can like prove that people with technology can stay longer at their own home. looking at using different technologies and also looking at different profiles from patients, because the one dementia patient is not the same as the other one. So I have to make different profiles like social contact. One person has more to do with social contact, one has to do more with medication or different kind of things. This is for the nursing home. What I want to do or want to prove with that research is that the cost and the workload can go down with using technology, but that the work satisfaction, feeling of safety, and the quality of life can go up. The quality of life is actually pretty hard because people with dementia further in the process, you can reach a little bit higher quality of life level for a certain amount of time, but after a while people are so far in the process that it's really hard. So it stops at a specific moment with improving the quality of life. Or at least that's what I'm thinking. This is the quick scan I was telling about. It's published in that magazine. I did an inventarization to dementia and technology in the field of 3 different technologies: help related to the symptoms of dementia, social contact for the person with dementia, and health monitoring and safety for the person with dementia. The first one is actually, for example, a medication reminder. The second one is persons with dementia could have social contact with their doctor or with other patients or with other caregivers. And the last one is you can think about sensor technology, for example, wandering around detection or gas detection or that kind of things. I included 18 international and 8 national studies. The first results look really promising from the literature I read. There were significant improvements in quality of life from the patient and the family caregiver, and effects on behavior like less falling down. The family caregivers and people with dementia are satisfied with the usability, but the purchase and user costs were really high from the technology because it's all new technology, so the costs are still really high. And because of that, the savings were really hard and really difficult to make. There has been done minimal research to work satisfaction from the caregivers working with the technology. And overall, the results look promising, but when I was looking for literature, it was really hard to find much scientific research, so there hasn't been done much scientific research into this field. So that's what I also say over here, that there's not much knowledge about the effects for people with dementia, the caregivers, and the healthcare organization itself. And technology is now often not legitimate in the care for people with dementia, and pilot projects are really necessary to prove things and to see what you can do with technology. As I said before, in my work, I start up different projects for people with dementia. These are some of it, and I will explain some of the projects I'm doing right now and what the first results are from these projects. One of it is PAL for dementia. It's actually personal assistant for life. That's the shortage of it. And it's a touchscreen at the people's own home. They have the touchscreen at their own home, and they can use it just to press on the screen. Oh. It's in Dutch, but it has an agenda in it. It has a life album. What's it? Narratives? Yeah, it's about stories from their past, and yeah. It has a diary, and it has PAL 4. It has several opportunities for video communication with a doctor, or for playing memory games, or looking up information about the disease, or all different kind of things. We started up like this with this head screen because we think the people with dementia will use their agenda, their narratives, and their diary the most. The diary is actually also for the caregivers. The caregivers can type something in during the day, what happened with the patient, and the family caregiver at their own home in a different place can look it up and look what's happened that day with the patient. Here you see the narratives. It has a photo album. It has a life story. They can look up films from the past. They can listen to music from the past, just to keep their memory, how far it's possible, up to a good memory. Okay, we started this project. It's a really small project. All the projects are pretty small because they're all pilot projects. We started it with 10 clients with a mean MMSA from 22. The MMSA is a range for how far the people are in dementia. These patients are actually in the beginning phase of dementia, so they're not that far. So they're still able to learn things and how to learn the system and how to work with the system. They were more forgetful than right for the age or has been diagnosed with dementia. The people who got the system, there was a danger. They forgot their medicines or they were bored. They were just sitting at the table and didn't do anything because they couldn't activate themselves for doing something. What we also wanted to try with this Fall 4 is less burden for the family. Family caregivers are most of the time really have a lot of burden because they have to care for the patient all the time, and the patient calls them like 10 times a day. And with this one, we want to like have an agenda for the patient so he can look up what he has to do during the day, doesn't get insecure about what he's going to do during the day, and he doesn't call the family caregiver all the time. Because when the family caregiver is getting burdened too much, that's most of the time the moment that the patient will go to a nursing home. And they had to have a prognosis to stay home for minimum 9 months. What we also did with this project is there was come an occupational therapist at their own home to learn them how to use the system. You can't just put the system over there and say, bye-bye, good luck with it, it won't work. What did the clients say? They say, oh, it could be useful as a reminder. Hopefully it's something to get less bored. They all said, because they're older people, they're like 70 or in the 80s, they're not used to using a computer. So they all said when I came there, can I easily break it? I'm afraid that I can't use it. So that's also a thing the occupational therapists have to say. You can press anything, you can press any button, it won't break or it won't go off. It's a way to stay updated. Maybe I feel more secure, and that's also a thing. I don't know if I will be able to use it. I never use the computer, so I have to. But you should actually not mention the word computer. You just have to say it's something to help them. It's actually not a normal computer. It's just pressing the buttons on the screen. The family caregiver said more or less, I have a burden of care right now. Maybe it's possible to do some more things on my own. I can go away for doing some grocery shopping without that I have to take the patient with me all the time and can't do anything on my own. It might be an entertainment and overview for my family member. The diary is nice for people, family who is living further away. They can look up what's happening with the patient. One person said, my mom loves music, but she don't know how to use the stereo anymore. There's so many buttons, and now she can just press one button and have her favorite music on. And they all said we need to teach them Pulver with a lot of patience. They won't be able to use it like in 1 week. We have to be patient with learning them how to use it. Another project is sensor technology at home. I just mentioned it before in my quick scan. We're using falling detection, wandering around detection, and gas detection. Three of the main problems with people with dementia still living at their own home. It's no technology that they're wearing because we saw in different other projects that if you dementia patient, you put them like a sensor on the belt when they're falling down that it will give an alarm. They put it off because they're not used to wearing that kind of technology. So we're using technology just in their own home, which they might see it, but they won't get it off. And the alarm is picked up by family caregivers. So they get an alarm on their mobile phones when someone fell down or went out the house or the gas was still staying on. And for security reasons, we also had a professional emergency room. If the person with the family caregiver didn't pick up his mobile phone, the alarm has to be picked up, and there was a professional emergency room for. The family caregivers all said it might be improving my feeling of safety, prevent dangerous situations, and nice to go away now by myself. So I know if I will go away and my partner falls down, for example, I know that I got an alarm, so I feel more secure to go out home by myself. It's great if mom can stay home for a longer period of time. It gives a bit of rest, but they're all really curious if it works. It's the same thing. It's technology that they don't know. They're not used to that kind of technology. So they say, let me see first that it works, and then I will definitely believe it. GPS track and trace is also a project we're doing. You probably know it. They have it for the cars and everything. But in the Netherlands, the systems are not that arranged for people with dementia so far. You can log in on your computer, and they can use it at a web page, see where the person are with an SMS or spoken text. We tested 5 systems with the caregivers, not with real patients, but with the caregivers. And the results were actually pretty disappointing. The electricity consumption was too high. The GPS receiver was much too big. You couldn't put it in a pocket from the person without the person knowing it. He would just get it out and throw it away. The system was really expensive. All the caregivers said, I won't be able to pay for that system. There was not always a good cover, especially in the urban area or with bad weather. But all the family caregivers said if it worked well, it would give me a bigger feeling of safety, but so far it doesn't work good enough that I will buy it or that I will use it. How much time do I have left? Because it's like 1 o'clock, we should finish, didn't we?
Yeah, maybe 1 minute.
Okay, cool. Maybe I skip this one then, or not. Yeah, I will be presenting this tomorrow at the Medicine 2.0 Congress. I don't know if anyone's going there, otherwise you can see it there. But that's where in a nursing home we use the watch for the people with dementia have problems with their sleep-awake rhythm. They get up during the night and are really dizzy or sleepy during the day. And with this watch, we try to measure their sleep-awake rhythm. And with measuring that and monitoring that, you could like change the medication or give the person a bath before he's going to bed, so he will be more stressed out and will sleep better. So with this watch, we're trying to improve the sleep-awake rhythm, and we actually prove that it's been improved. Yeah, it does work. That's what I wanted to say. So it has some more slides, but you can probably see it on the thing. Okay, I'll go through it. Here you can actually see that this was before the person got a medication change, and he has peak periods during the night, so he's awake. And after the medication change, you can see that he's longer periods of sleep. I can stop here for the questions. That was where we're gonna go, I think.
Well, thank you both for your presentations, and I guess I'd like to turn it over to the audience. I'm sure there are many questions that people would like to ask, and that our presenters would have the opportunity of answering. So I'll open up the floor open to questions, and I'll get the mic to you if you want to ask a question. So anybody in particular want to start? It's always hard to be the first one. Here's somebody here. Maybe just state your name and first and then your question.
My name is Hassan Adibi, and I have a question related to the GPS system that you mentioned.
Yes.
You mentioned it didn't give good results partially because of the response back to the system that didn't work well in urban areas and bad weather and so on and so forth. What type of technology do you use from the GPS system to the caregiver? What type of mobile interface or?
Yeah, it's just a GPS mobile interface. I don't know the specifics of the technology, what's in it, but it's just a track and trace system which using the satellites around the area. And the person can log in on the computer and can see on the map where the person is, or they get text messages on their phone or a spoken word on the phone.
Right. So it's cellular based, right? It's
yes, it is.
Okay.
Yeah, that's what they're using right now in the Netherlands. Okay. I know actually about a company, I think it's in Canada or North America, that's using not the satellites, but it's something different, and it's supposed to be working better. But in the Netherlands, how do you say, the persons which gonna use that are too small for that company to come to the Netherlands because it's not profit for them then.
Well, so. I assume that WiMAX system should give very good performance in terms of coverage. And
so that's true, but it's also another point with the GPS system that if you have people with demented people and they have the GP
on their body,
on the necklace or the pendula, they are walking very fast because they want to be quicker at home because they hate that thing on the neck, and they have no idea. They're walking out the streets and looking around for what is going on. They cannot grasp that. That was not on your project, but on another project we did.
Thanks.
Don Cowan. Lots of questions actually, but I'll focus on one. You used diabetes as an example of a chronic disease, and diabetes, of course, if you don't take care of yourself, the short-term consequences aren't bad, but the long-term consequences are terrible. You know, amputation, kidney failure, you name it. One of the issues is how do you get anybody to use this technology? Because, you know, well, I don't feel too bad today, even though my blood sugar may be a little bit high or what have you. We've been working with this stuff now for close to a decade, and one of the biggest problems is getting people to use the technology. We built in a whole bunch of things, which I won't go into right now, which kind of pushed them in that direction. I'm just wondering what your views are.
And especially diabetes is a very difficult population to handle with technology because they don't believe in exercise and they don't believe the technology as well, and they don't want to change anything. And we found out in a review, we did a systematic review in advance and an international review, and we saw that the best results were with people included that have a range of improvement. For instance, people with bad habits and insulin, you call that insulin dependent people, that we have seen very good results with that. But in the Netherlands, we have the diabetes lifestyle coach for people that are in a convenience way. They can use it or they don't. There was no strict population in that. So they have it available for everyone. And we saw that people that have diabetes type 2, they already know a lot about their behavior and their sickness. So in advance, they like the internet. In the Netherlands, 80% of all people have internet access. So that was not a problem. The technology access was not a problem, but there was no motivation. They had no added value in it. They said, I know all these kind of things, and I don't want to know what I don't know at the moment. And I only have interest in some e-coaching, lifestyle coaching, some tutor that guides me in my behavior. And can technology do this? And that's not a question. For the internet-based programs, they like it, but after 2 years they have no added value anymore. So they are looking for a new technology, but they have no problems with technology in principle, but they have problems with their behavior. So, and that's, their behavior, their lifestyle, and we are looking for, we know, for instance, that a robot, they have the iCat, they love the iCat, they have a relationship with this iCat, it talks to him, and it talks back. Yes, it's like we have the statues for the Christian statues. They pray for it, like things like that. There are more creative methods for technology than internet. But the feedback and the motivational cues are very important. It is not what people are talking to us for. They hate technology. For the average, the mean age was 62. Even people for 80 years could use internet, but that's not the question, I think.
We'll take one more question from the audience. I know we're running over time, but I'd like to have one more question.
John Young from Canada's Technology Triangle. My question is really about the ecosystem of the research, but also policy and the financing and so forth. So for this to work, it really needs to be looked at from the point of view of ease of access, ease of use, affordability. The patient, but also the caregiver's ability to take advantage of it and feel that there's a positive result. So all of these combined, not just one individual thing, but all of these combined need to be put into action. And the problem at the end of the day is that somebody has to pay for all of this. And so, the research is great. Maybe even the policies that government provide are great and the government's supporting it. But how are all these millions of people who have dementia and problems with diabetes and other age-related things, how are they going to be able to take advantage of this?
That's why and that's the big question at the moment, not only in the Netherlands but also in Canada, I suppose. But we know that the problem is that the insurance companies in the Netherlands, they pay a lot for their clients. They pick up the clients. They say, if you are a client for this insurance company, then you have for free service that kind of tools or technology, but it's only for 1 year, and after that the insurance company saw I have no interest anymore because we have a lot of investments and not many people enough that use it, so I'm not and have no interest anymore. So we are looking now for new models for financing technology, and even we are talking now about that patients, especially chronic patients, want to pay for it. And then we have another model for a business model, as when patients are paying for their service. In the Netherlands, all the healthcare service is free. So this is a totally shift in their mind for paying for a certain service for healthcare management. And now we have healthcare platforms in the Netherlands. That means that insurance companies, governments, investors, and patients groups as well as caregivers, hospitals, etc. They come together and they have a platform discussing what are the benefits for a certain technology and how we can make it affordable. And that's what we call the business model that came up, that we make workshops to do that. And after a few, sometimes 4 workshops, then we have an agreement, and then they are looking for new investment models. But that's the point. It's true.
I'm really sorry to have to cut off this discussion because I think we could probably go on for some time, but our speakers will be here for a short period of time before we have to go to lunch. So please feel free to come down and introduce yourself to them and let them know your particular area of interest. I am very excited that our guests have come from the University of Twente today to speak to us. Both the University of Waterloo and their university are very eager to work together, and we are working towards an MOU with their university so that we can formalize this arrangement so that we can work together effectively or more proactively together. That would include perhaps collaborating on a research project, student exchange programs. So I'm sure that there are students here that would love to go to the Netherlands and vice versa. So if you are interested in this collaboration, please let me know. As I said, I'm Shirley Fenton, and I'm the managing director of the Institute. So send me an email or give me a phone call, and I can keep you up to date on our progress as we go down this collaborative work together. So thank you for coming today. I really appreciate the wonderful audience that we have here, undergraduates, graduate students, and professors and visitors from our community. So thank you again, and hopefully you'll come back to our next seminar on October the 7th.
I have just one thing. We have our emails here, so you can keep in contact with us, and we also have the URL, the address of our research center. As you can see some project. We have also a newsletter in English, so if you are interested, you can join to our newsletter.
Okay.